Are we live?
Yes, sir.
So,
Started the recording, sir.
very good morning, everybody. Welcome you all for another session of Sunday Breakfast Meet. We have today a few very good speakers. We have Mangal sir, we are President Secretary. So, let's start the webinar. So, the first speaker we have Dr. Joydeep Mandal, then we have Dr. Prabhu, then we have Dr. Sudhanshu Anand, Dr. Ketan Kumar Gandhi, and Dr. Washif Khan. So, without wasting time, I'll request Dr. Joydeep Mandal to share his screen.
Good morning, everyone. I'll be sharing a case of, sorry, parafocal osteotomy in a case of oblique plane deformity with stress fracture of tibia and fibula. So, a 53 years old male, he had a history of both bone right leg fracture 9 years back. He was treated by bone setters. He was managing his daily activities with some amount of deformity. He had a few healed sinuses over his leg. He presented with increased pain and unable to bear weight for last 2 days. So this is the X-ray at presentation that shows a varus and trochanteric deformity with a fracture of tibia and fibula, and there is an area of cross union between tibia and fibula also. These are the deformities in AP lateral, and there is the plane of no deformity. So that's an oblique plane deformity. If we plan that, so in the AP X-ray, there is a 31 degree of apex lateral deformity with, and in the lateral X-ray, there is a 23 degree of apex anterior deformity. If we put that in the graph, so the deformity comes around of 40 degrees in the with apex anterolateral and 36 degree to the horizontal plane. If we put a hinge axis perpendicular to the plane of the deformity and put our 160 ring, so the hinge axis passes through hole number 1 and 14. So if we plan the cora and osteotomy, the cora is coming around just below the fracture around the area of the cross union. So that area is completely sclerosed, and it's very difficult to perform osteotomy there. And also it will take much more time to heal. So the best place to do the osteotomy is just below the area of the cross union using rule 2. This is the intraoperative Siam pictures. So once we did the osteotomy and we corrected, we got full correction, and the osteotomy was not far away from the cora. So the displacement was not a lot, and the bone contact was also very good. So we decided to go for acute correction and fixed complete fixation of the frame. So after osteotomy, you can see the middle fragment, it becomes free because above it was the fracture and below the osteotomy. So I've also added a pin from the lower part of the ring. This is the X-ray at 1 month and X-ray at 4 months that shows consolidation of the osteotomy, but the fracture consolidation is still doubtful. This is X-ray at 6 months, where the osteotomy has been completely consolidated, but fracture was still doubtful. So I asked the patient to check his gait. So the gait has significantly improved over the past months, and this is the gait after dynamization. So I've decided to remove the frame and applied a PTB cast. In next 1.5 months, the fracture has completely healed. These are the clinical pictures, and this is the final gait of the patient. So parafocal osteotomy, it's a concept that has been given by Italian surgeon Poltrinieri. It separates the area of pathology from the area of bone regeneration, and especially helpful in cases of where we are dealing with sclerosed bone, where doing an osteotomy is difficult and also difficult to achieve union in that place. So in that case, osteotomy can be done through the healthy bone and achieve similar results. Thank you.
Joydeep, where is his? Show us his final X-ray. Do you have?
Sorry, sir. Couldn't hear you.
Do you have his final X-ray?
Yes, sir.
Just put that up, na.
This one, sir.
So in this there is no, after the cast was removed
This one is the last X-ray, sir.
on the left side.
Yes, sir.
Okay. So there is still a little bit of
Fracture
a
line, sir.
fracture line
Yes.
seen over there.
Yes.
So meaning the patients can still, with a strong fibrous union, they may still walk on a strong fibrous union without trouble. Plus, if you say that there is cross union,
Yes.
there may be force transmission across that cross union also. What is the advantage you got out of acute correction?
Only the advantage is, sir, the patient doesn't have to move all the nuts, and the amount of translation was not a lot, and the bone contact was also very good. That's why I went for the acute correction, sir.
No, I understand, but you have put on the Ilizarov fixator.
Yeah.
So might as well take the advantage of the Ilizarov process in terms of distraction, gradual distraction, bone formation, increased vascularity, etc. Here you have given a completely mechanical solution.
Yeah.
You had the opportunity to give a mechanical as well as a biological solution. That is number one. And just go back to where to your frame, some X-rays you had where you put a screw across the
Yes, sir.
fracture. Yeah. Right. Now, this one is holding your osteotomy.
Yes.
You have one pin proximal to the osteotomy that you did.
Yes. Yes, sir.
And you have, I think, two wires, something distal to the osteotomy. You also had a heel ring or what?
Yes. Yes, exactly, sir. One heel ring.
Okay. So I have had trouble. I just recently, actually, I did something similar, and I had trouble with that proximal osteotomy healing. So you can have trouble in this because there is hardly any then dynamization between the lower fragment and that osteotomy, the one which is distal to the old fracture and the new osteotomy which you did. There is no dynamic forces acting over there. So that would have been one more sort of advantage of, because that non-union which you had, the stress fracture, was relatively immobile.
Yes.
So what I would do in such a case is put on hinges and do a gradual distraction and not fix proximal to that. Leave that non-union stress fracture rather as it is, and I think that would heal. That is number one. Number two, I believe it's a better idea to use hinges and a motor. Now, the fact that at the end your rings are not parallel to each other, especially on the lateral.
Yes, sir.
That signifies that our planning was not proper.
Yes, sir.
That is why otherwise the rings would have come perfectly parallel to each other. So that is, whenever we get something like this, we have to go back and look at, okay, what was the issue in the planning where I didn't measure the lateral portion adequately, or whatever it is. So because we have had to overcorrect here, and this may be because of your acute correction. Probably it would have worked with the gradual distraction according to your planning. Did you do a separate fibular osteotomy
Yes, sir, I did.
through a separate incision, right?
Yeah. Yes, sir.
So many a times, even in infected non-unions, when I have this kind of sclerosis and all that in that region, I normally say you should do a oblique fibular osteotomy, and the fibula will override. But in these kind of cases, the fibula doesn't override, and I have to then resort to a slight excision of the fibula to allow that overriding. Also, your fibular osteotomy is not was it oblique or was it like a
No,
transverse?
I had to do fibulectomy, sir.
Right. So that may be a cause that enough fibulectomy is not done, so it kind of impedes your movement.
Could be, sir. Sir, one thing, if I am doing a gradual correction, then the middle fragment is free. There is fracture above and osteotomy below. So then
Yeah.
I need to put a pin from the second ring, right? Otherwise, the movement can become through the fracture also, no?
What I would do is I would do the distraction and see
Okay,
if that stress fracture is distracting,
okay,
then I may consider putting the pin. But it's very likely that the stress fracture will be held in position because now there is a osteotomy which is free to move. So
yes,
the sort of nature will choose the one which is easier to move, and that one will not necessarily get distracted.
okay,
But
sir.
if it does, yes, you have a point that you can go in and just put in an additional pin from the second ring.
Okay,
Or else we can use a third ring in between.
Only
put
for
pin.
that, yeah.
Yes.
Because there's single pin in between.
okay.
That's not quite stable.
The final thing I want to say is generally with these hinges, whenever there are hinges on the rod, then that is relatively speaking compared to straight rods, that is unstable. Even if we tighten the hinges down fully, so I would tend to use straight rods with coupled washers wherever I can,
Yes, sir.
rather than using hinges. But I don't know, that's a personal choice. Amar, what do you do?
Sir, I generally, whenever this angulation is more than say 6-7 degrees, I would prefer to use hinges instead of coupled washers. Up to
Yeah. When
certain,
it's more than 7, but
yes.
if it is possible to use coupled washers, then would you
Yes.
prefer coupled
Yes.
washers or not? Is
Yes,
what
sir.
I'm
Yes.
asking.
Yes, I agree.
Bhola.
Bola sir will be using 6 axis.
No, but after the 6 axis ka kaam is done, Bhola, you are muted. After the 6 axis ka kaam is done, do you change to straight rods or not?
I just I just connect the rings, proximal as well as distal rings.
Yes.
Might be it is we use, if the angulation is very small, then we use only conical washers. If that is too much, then we might use fixed hinges sort of thing.
Right. Okay. Thank you, Joydeep.
Okay,
So
thank
that's
you.
good case to see.
Shamsul sir, our next speaker is Dr.
Dr. Prabhu is our next speaker.
24 years young male patient presented to us with a history of gas cylinder burst injury in Saudi Arabia, primarily treated in Saudi Arabia with debridement and Ilizarov fixation, sir. And he presented to us after 2 months after the surgery. In the image, we can see there is an open wound. The Ilizarov fixator 4-ring construct has been done. The problems here we can address are there is bone defect as well as soft tissue defect, exposed bone. There is flexion deformity at the knee. There is quadriceps wasting. Patient had foot drop and shortening, and the values were ESR was 152 and CRP was 88. So the plan was 2-stage procedure. before that one, the problems in the fixator was, the first ring was above the level of the fibular head, sir. It was not fixing fibula and tibia. Proximally, fragment was fixed with 2 rings, and distally, the fragment is fixed with 2 rings. The distal ring is not spanning the distal tibia fibular joint, and it is way high up. And we can see in the picture, the rods are already bent under stress. So the plan was in stage 1, debridement, following oblique fibular osteotomy and revision Ilizarov, and gradual docking. In stage 2, lengthening was done. In the procedure, this was the construct we have done. There was a 3-ring construct. Primary debridement was done at the open injury. The exposed bone was trimmed off. And these are the X-rays post-surgery. See, in the AP X-ray, the proximal and the distal fragments are forming an angulation deformity. And in the lateral view, there is angulation as well as some translation deformity. So the defect was treated with VAC. So there are 3 issues right now. One is to correct angulation as well as translation, and to fill the defect, means to do docking. So plan was to do 6-axis correction. This is the green line represent the anatomical axis of the proximal fragment. Yellow line represents the anatomical axis of the distal fragment. And the blue line represents the correction post deformity correction with depth fix. This is the lateral view corresponding to the deformity correction. So the first was to align angulation and deformity. In AP, the alignment was restored. In lateral view, there is some amount of translation which can be seen on red view. So the second step, depth fix program was given only to correct the docking, means to oppose the fragments. So at the end of stage 2, the docking, we can see the posterior fragment is itching the proximal fragment. So at this time, we tried for translation by 5 mm, but the posterior fragment was not allowing translation. So one more plan was given to distract between proximal and the distal fragments. Even with giving the program, there was no translation happening between the proximal and the distal fragments. So the plan was to do posterior tibial osteotomy. Here we can see with compression or docking, the wound has decreased in size. There is good granulation tissue at the wound exposed site. So we took the patient from the anterior defect. We did osteotomy, posterior tibial cortex osteotomy was done with a gentle tap. So these are the post-op wounds and X-rays. In post-op wound, we can see the defect, and the AP and lateral view shows some amount of translation in the anterior posterior view and angulation deformity in the lateral view. So new depth fix program was given to correct the translation as well as angulation deformity. This was the X-rays post planning, post depth fix program. So the only defect what is right now is only the defect, this docking side to be, the defect part to be docked. So 31 mm of compression was given. By the end of this compression, these were the X-rays.
Ashutosh, please mute yourself.
We can see the wound is completely healed. On lateral view, we can see invagination of the skin, but on X-rays, there is good amount of bone-to-bone contact. So these were the clinical features. Patient was walking with sole raise as there was a defect of about 8 centimeters. This is walking video. Patient was asked for touchdown mobilization. By the end of 2 months, 2 weeks, the ESR and CRP was below range. Wound was dried. Food was plantigrade. And the limb length discrepancy was about 8.2 centimeters. So the stage 2 was planned to do corticotomy. Under image intensifier guidance, we have placed the Ilizarov wire to see for the level of osteotomy. multiple drill holes were done, followed by osteotomy was used to do the complete osteotomy, and we can see the complete osteotomy has been done. So distraction was started from post-op day 8, and these are the X-rays after post-op day 16, post-op day 29, and post-op day 69. By the end of post-op day 69, 4.5 centimeters of distraction was achieved. By end of 4 months, 7.5 centimeters of distraction was done. 7.5 centimeters of new bone was formed on AP and 7.6 centimeters on lateral view. Here we can see good consolidation, equal good quality regenerate has been formed between the proximal and the distal fragment. These were the clinical pictures at the end of 4th month. The straight rods were converted to telescopic rods at that time. This is the post-op X-ray at 10 months. The regenerate has nicely consolidated. Patient doesn't have any difficulty in walking. He's walking nicely. At 10th month, we have dynamized between the ring 1, ring 2, and ring 2, ring 3, so that our further consolidation will happen and union will be achieved. At post-op 14 months, this is his walking video. Stress test was done to remove the fixator. Post fixator removal, the patient was given brace, below knee brace. This is his walking video. Post 1 month fixator removal, patient is walking with the brace without any pain or difficulty. This is the 2 years follow where the regenerate has completely calcified. Patient had problems of foot drop and complaints of hind foot valgus and clawing of toes, for which plan was done to do subtalar fusion, tibialis posterior transfer to intermediate cuneiform with peroneus longus tenodesis, peroneus brevis lengthening, and claw toe correction with. This was the surgery which was planned and executed. These are his post-op clinical pictures and X-rays. This is his walking video post-op 4th month. So, summary coming to successful management depends upon stable fixation, meticulous debridement of the meticulous debridement with complete excision of non-viable bone, prioritization of bony union over bone preservation, accurate use of 6-axis in docking and alignment, careful consideration of distraction rates in distal tibia lengthening, awareness of challenges associated with distal to proximal tibia lengthening. Thank you, sir.
Good.
Thank you, sir.
So I will lead off with some questions
Yes, sir.
for say Amar, Joydeep. I think you all don't use 6-axis, right?
Yes, sir.
No, sir.
So in a case like this, my contention is that 6-axis allowed us to do so many manipulations without any change in the hardware, and allowed us to get it. Just go to the last X-ray, Prabhu. Allowed us to get this proximal thing completely perfectly aligned to the extent that this healed without any bone grafting. So what is your take on that? I say for these kind of issues, you should use 6-axis, because that last one, AP lateral, the previous one, Prabhu.
Yes, sir.
Yeah. So what is your take?
Means the same thing we can do in with hinges and washer also. Regarding angulation, probably it could have been prevented. Means at the time of surgery only we could have prevented angulation, and translation most of time we can correct easily with this hinges and washer. But yeah, 6 axis is a very handy, and if it's an available.
Yeah, I find you can do it kind of, millimeter to millimeter, degree to degree. That's what I'm saying, without any झंझट.
हाँ
Sir,
सर, पर सर वो उसमें भी हो ही जाता है, मतलब कोई दिक्कत नहीं आती है यूं।
No, but number of surgeries are reduced, na, Amar. Taking the patient to OT for
Sir, we
more
never
time.
take
Even
sir,
with what Amar is saying, you don't need to take the patient to surgery.
हाँ,
It's only that you have to then you have to actually change the direction when you want to do translation, align it and stuff like that.
no sir, what we do was first we correct angulation. Once angulation is corrected, then we do correct translation. But
Hmm.
and second thing regarding this refreshing of bone ends, I would have done at the time of index surgery only. So because with frame on, we are supposed to work in a constrained space. So at the time
No,
of
no, no, no. We didn't refreshen the bone edges were freshened earlier only, first time only.
no, but
Later, what happened was there was a posterior cortex which was hinging and preventing the. So we just broke that cortex and pushed it behind so that it doesn't come in the way. That's all. तो वो खाली एक osteotome लेके we had to break it and push it behind.
Sir,
Joydeep,
in this case, sir, we could have done the corticotomy in the very first sitting, sir. Then at the time of docking, we could have corrected the deformity with hinges only.
no, the reason for not doing the corticotomy in the first stage was that you saw his ESR, CRP, and all that. So I wanted to be sure that his infection is kind of settled before we go ahead with the corticotomy. So
Okay.
that has essentially added, you can say, 2 months.
Yes.
That's all, nothing more. So that is not a big.
another point is
हिमांशु जी हाँ बोलो.
sir, in a situation where we are transporting from distal to proximal, what is your take on applying foot ring to prevent equinus? Foot ring.
This guy didn't get equinus.
Yes, didn't get,
But
but
I have not had a problem with equinus if you use a proper strap and all that, they don't get equinus. But yes, clawing of the toes is a problem.
Yes.
So one can argue whether one should do that when you do the corticotomy itself, so that the clawing of the toes doesn't happen. More than see, there is nothing which causes equinus much, in the sense that this is the flexors of the toes, etc. So if you keep your foot straight, the toes will get a little clawed. What do you do?
Means to prevent clawing of toe, I insert KYs in all toes.
All toes. Okay.
Yes.
And the other thing of note was that when you do distal to proximal, the rate should be slower.
Yes.
Not the usual 1 millimeter, because that area doesn't have a good blood supply. So I always do it at 0.75. What do you do?
Always 0.75.
Yeah. So I think there is one question in the chat. Aradhana said, why
subtalar fusion?
Subtalar fusion. Because he had developed a valgus due to the same thing. Just like the clawing of the toes, there can be issues with the heel also, which technically one could say that could be prevented by using a heel ring. So
yes, sir. Yes, sir.
Subtalar fusion was because of that. And Varush has a question. What, Varush?
Sir,
what is your question?
We find the situations where the fracture is in the metaphyseal region. And
What?
one fragment, we
Your
find
voice
that.
is... Yeah, say. Voice is not clear. He's gone off. He got disconnected, I think.
Sir, the patient also had FFD preoperatively. So it got corrected with physio.
that with physiotherapy because there was no other problem. Na? They had just kept him in a fixator and you see the way that the fixator was, the moment the patient keeps the fixator on the bed, he will develop a flexion deformity. So that is just to point out that, you know, when you have a fixator on, you should be, patient should be doing active physiotherapy and not just letting the fixator lie on the bed. Just the attitude of the way the patient was in bed would create a flexion deformity.
Okay. Another thing, sir. Sir, you have used one ring proximal to the fracture. So
Yeah.
every time, sir, I'm doing that in my cases, I'm struggling with pin tract infection. I think it is creating putting the pins in a lot of stress and they kept getting loosened, sir. Do you, sir,
Go
always
back.
do that?
Yeah, almost always. Just go back to show the frame, Prabhu. So we have we have two in this just the frame. That's all. Yeah. So we have usually in this three wires and two pins. So one of the pins is from anterolateral to posteromedial and one is from anteromedial to posterolateral. So these two pins, to a large extent, most of the problem, I think, comes from flexion extension forces when you put in only wires. So to counter that, we have these two pins. Is there a just Prabhu, go ahead, show if there is a X-ray. Yeah. Okay. So you see, one is below. In this one, we didn't have, I think, space for above or what? How many were there? Two. But we have not changed his pins or wires. So that has not really been a issue. That is number one. Number two is once it is docked, ring number 1 and ring number 2 effectively become a block because that bone is under contact. So here we may do the compression a little faster because here there is no question of biology. We just want to close the gap. We
Sir,
don't
we
have
could
to
have one
compress
pin
that
above
1
also.
millimeter.
So we could have applied one pin proximally also to the ring because there's one pin only. Distal.
I think so, yeah. But there must be a reason why maybe there was no space or I'm not sure why. But essentially because this is one of the reasons that once they come into contact, they are effectively one fragment. So ring 1 and 2 become a block.
Right.
If I'm doing the reverse, where I'm distracting from proximal to distal, then that small fragment must have two Shan spins. You get the difference.
Right,
Here
sir.
we are closing that gap and then ring 1 and 2 are that the bones are in contact. Whereas if I'm going to distract for 6 centimeters, then for that much time that proximal fragment is going to be a sort of independent fragment and that will be then subject to even more forces.
Right.
But yes, the point is well taken that you can put in two screws also, or probably should put in two screws also. There must be some reason why we didn't put it on over here.
Right, sir.
Okay, sir. Sir, should we move in for the next speaker?
Yeah, there's
Yeah,
one
now,
question.
any Bhola has any questions or?
Sir, if we see
There's
the
one in the chat box also.
Yes.
Yeah.
we see the last X-ray lateral view, we find that there is some flexion at the proximal fracture site, but that is being compensated with the help of soft tissue distraction. What I mean to say, sometimes bony issues, they give rise to something which can we get the last X-ray lateral view, sir? The after correction, sir. Still the last. Yeah. That last X-ray, if we see, most probably I find that there will be flexion at the bony level, but that is being dealt by the soft tissue being dissected at the soft tissue level. So net FFD of the knee is not present.
No, the one is what you think is a flexion deformity here is partly because of the rotation. You see the condyles are not superimposed. Just go earlier one if there is X-ray with the condyle superimposed. No, these are all X-rays which he has sent us, so they are not superimposed. One more.
Yeah.
No. Yeah, but okay, your point is taken. I don't think there is a flexion deformity here because we've corrected his flexion deformity, rather the PPTA and all that with the 6-axis. So what appears as a flexion deformity is more of the apparent, but he also has on this picture you can see he has hyperextension at the knee. The overall look of the leg is femur to tibia is hyperextended,
which might be due to the soft tissue, which is
correct.
more.
But there is
I
no.
mean to say
It's
there
not a
is
question
always
of
compensation.
compensation.
Yeah.
It's not a question of compensation. So you will get visible hyperextension only if there is hyperextension at the knee. If there was a flexion deformity, that is the PPTA was more, then the leg would remain would appear straight. You get what I'm saying?
Yes.
Yeah. So here I don't think that
Alignment is okay, sir.
Huh?
Alignment is perfect, sir. Lateral view alignment is okay, sir.
Alignment is good.
It is because of the knee, sir. It is because of the knee. That is why it's going into hyperextension.
Right. Varush?
Yes, sorry, this thing got cut previously. So most of the times when we have this metaphyseal, diaphyseal region fractures, one fragment is large and the other fragment is near the canal. Can we use the fibula strut rather than doing an oblique fibula osteotomy? Can we excise a small fragment of fibula and put it in between the two fragments so that alignment is maintained intraoperatively itself? Is it possible?
The fibula will be swimming in the large metaphyseal fragment. So the fibula is not going to give you alignment. When you've got a fixator on that fragment, why do you need a fibula?
But we did not get perfect alignment intraop. So is it going to help?
No, that is because that is a technical error in terms of the way that we did it. So I don't think the fibula will help you to get that alignment. That is and that's the advantage of the fixator, that if you don't have alignment, just go back go back to that initial post-op, Prabhu.
Yes, sir.
This question of alignment depends on how, go on. Yeah, okay. So now that's fine. Because I'm drawing the lines, this looks, I can say it's malaligned, but 8 out of 10 people would say that this is okay and acceptable. Even if you compress this, that distal fragment is going to go and hit the proximal. So this is what we say, better is the enemy of good. This alignment is kind of pretty good, but I want to get it better. Now, putting in a fibula over here is not going to help. Someone asked, Aisha asked, any role of nerve exploration in the first debridement? To me, no, because there's already a large wound over there, and this was a blast injury. So I don't think that common peroneal nerve is going to come back. But yes, one could explore it. I would not argue against it. Personally, I don't think that I would do it, but I guess you could. Anyone else?
Excuse me, sir. Couldn't we have done made the fracture transverse distally? Would it have been a better outcome, sir? Matlab, in the docking sense and the union sense, had we made the distal fragment transverse?
No, we saved about 2.5 centimeters. No, by doing it this way,
Okay,
we
sir.
saved about 2.5 centimeters. So I don't. By making it transverse, it may have been a little easier. It would have added a little more time, but with the 6-axis, I don't see that there is any problem in terms of docking it.
Right, sir.
Right. I think we can go ahead. Anyone has an opinion on the common peroneal nerve? He had a foot drop on day one. So would you have done a exploration of the nerve? What is the case for exploration of the nerve?
Sir, if it is a long-standing injury,
This was a
so
couple of months at the most.
so let it recover on its own or do a tender transfer. I feel this way. Exploration doesn't help much, sir, in common peroneal nerve.
Now, if it is a particular type of injury, it may help. But here, this was kind of a blast from the medial side. You can see that the fibula is, broken with a gap,
You're right, sir.
and all of that anterior tissue in that gap, that is the anterior compartment of muscle, is gone. So even if the nerve is okay, that the likelihood that the muscle is working to dorsiflex the foot, to me, is very low. So I would not. That is the reason I would not bother with the common peroneal in this particular case. If this was just a closed injury with a fibular injury, then maybe I would. Okay, thank you. Let's go on to the next case.
So next we have Dr. Sudhanshu.
Good morning, everyone. I'm sharing a case of management of infected distal tibia non-union. So we had a 63-year-old male who was diabetic, had a fall from height, and sustained a compound fracture of right distal tibia, which was managed initially with wound suturing and an external fixation and a rush nail to the fibula. 1 month later, the fixator was removed and plating was done. 2 months post that, the patient developed cellulitis with infection, for which debridement and implant removal was done. And the culture showed MSSA, for which antibiotics were started for the patient. So the patient presented to us with 2 discharging sinus and the anterolateral aspect of the ankle, as shown in the photo. And on the preliminary X-rays, there were 6 issues. First was the infection. Second was the non-union. Third, the distal fragment was small. Fourth was the obvious deformity in the lateral view, which is very curvatum. There was obvious shortening, and the patient was an uncontrolled diabetic. So we made plans in 2 stages. The first stage was to remove the implant, do a thorough debridement, apply Ilizarov fixator, and put in stimulant and give antibiotics. And the stage 2 was supposed to be planned later when the infection settles for lengthening. So intraoperatively, a posterior medial cortex was seen to be healthy, which was retained. And the anterior lateral defect was filled with the antibiotic cement spacer with 40 gram with vancomycin. These are the immediate post-operative X-rays, and you can see the antibiotic cement spacer. The alignment looks also okay, and the distal fragment was too small, so it was decided to span the ankle, and pins were put in the calcaneum. This is the post-operative wound image. Because of the tight closure, the distally it was decided to put on vac. And for the culture, the intraoperative culture showed Staph aureus, and injection cefazolin 2 gram IV was started for 6 weeks. These are the successive wound images at 1 month, 1 month, 1 week, and 1 month, 1 week after that, which shows progressive healing of the wound. These are the post follow-up X-rays at 1 month, 2 months, and 4 months AP view showing progressive healing. And this is the lateral view showing the same. The patient then was walking with walker support, full weight bearing, is shown. And then we waited for the wound to heal completely. After that, CT was done to see the healing of the bone. And then later, the stage 2 was planned, which is the removal of the spacer and to put in a bone graft. So the CT was done, which was showing healing at the posterior cortex in the sagittal view and in the coronal view. You can see bone formation there. So the stage 2, the cement spacer was removed, and we put in an allo with autograft. These are the post-op X-rays at 2 months and 3 months, the AP view. And this is the lateral view showing good healing at the posterior aspect. And then at 3 months, union was checked under the C-arm. We disconnected the rods after the stress test and to check for the union. And we decided to put on a cast for 2 weeks, and the patient was again walking. After 2 weeks, the cast was removed and the patient was walking with the brace. These are the follow-up X-rays at 7 months, 9.5 months, and 1 year, 3 months, showing good healing. And these are the lateral views showing the same. And this is the patient walking with the brace at 1 year and 3 months. And these are the post-operative this clinical photo showing good range of motion of the knee, ankle. Obviously there was one issue of the shortening of 3.2 centimeters on the right side, but the patient is managing with the shoe race. So the take-home points was to retain the healthy bone whenever possible, and bone transport is always not required every time, like in this case, and to tackle the infection from all directions, to excise the infected bone, take appropriate cultures, to give good stability with the fixator, and then adequate antibiotics with the PICC line. Thank you.
बोलिए बोला साहब. म्यूट है, म्यूट. यू आर म्यूटेड.
Sir, I think he has very beautifully managed this case, and he has given very good message that always it is not, you can even go without excising every part of the bone circumferentially at the site of infected non-union or non-union. Whenever you find there is part of healthy bone, you can retain it, and the results are, which he has shown, they are good.
अपना तीसरा एक्सपर्ट कहाँ गया? कौन है?
सर पाटिल सर आज अटेंड नहीं कर पाए.
अच्छा, हाँ तो तू है ना उधर का.
नहीं सर मैं कहाँ एक्सपर्ट. नहीं पर nicely managed, and in elderly patient with diabetes and this thing, at times length is not that important. Union is our first priority, and elimination of infection in union should be first goal.
So I think 2 or 3 people had advised him amputation. But so the important thing here was, one, identifying the areas of infection. Second was appropriate use of a ID specialist. Extended, he had 6 weeks of IV antibiotics. I think 6 weeks of IV antibiotics is impossible with a cannula. You have to put in some kind of a PICC line or a central line, because that's the only way you can reliably give. So these are not specifically orthopedic issues. They are kind of parallel issues, but they have to be addressed if we are the captain of the ship in terms of dealing with this patient, you know. And this patient was very cooperative and all that, so that was not a problem. But again, here the fragment was so small that, and the ankle was basically gone, so extending it across the foot was the only way to hold it well. I think we had something across the talus also, if I'm not mistaken. Yes, there was hardly any distal tibia. Yeah, there is one wire which is into the talus. So that entire thing forms a kind of block. So 2 questions on the chat. Antibiotic bead with WAC can be used? Yes, can be used. But with antibiotic beads, the problem is it gets absorbed, and then that skin on the top will stick to granulation at the back. So then going in again becomes a problem. So generally, whenever I want to open it up again, I know that I want to open it up again and put in graft, then I will tend to use a cement block rather than antibiotic beads. And the second comment, I think, is from Jayant. In cases of polyostotic fibrous dysplasia, doing an excision and transport is a good option, or should we give
This could be
bisphosphonate?
discussed later on, sir, because not related with this case.
Huh.
I was having a case just recently, saw it in the OPD. I will share the X-ray. I'm just trying to drop it.
Okay. All right. We'll do the cases and then we'll talk about that. WAC is in exposed medullary canal. Is it contraindicated? Yes and no, in the sense this is not an exposed medullary canal, since we have closed up the whole thing with that cement. So you have to be careful about it. You have to use lower pressures, but otherwise I don't think it is contraindicated. Which previous case? Yeah. So that's what. If you use it carefully, I don't think it's not a problem. It's not directly on the medullary canal.
Sir,
Okay, sir.
I have a question, sir. Sir, do you think in these cases putting a cement spacer improves the healing potential of the bone when you put the grafts later, like
Like a
mascule?
mascule?
Yes.
Could be. But in mascule itself, my kind of success rates have been a little variable. So I would say that my primary use for this is to keep a space where I can add the graft. That cement may form a bioactive membrane which will help with the graft healing, but that's not my primary reason for putting the cement, if I can put it that way.
Okay, sir.
Yeah. Well, what is your Amar, Suresh, Jayant, what is your opinion on Karthik's question? WAC in exposed medullary canal. Theoretically, it is contraindicated, but in both of these cases, I don't think there was an exposed medullary canal. What do you have to say? Amar first.
Sir, in such cases, I have not used wake, but I do accelerated compression. So, say in a span of around 2 weeks, most of this defect gets filled.
Okay.
Yes.
Suresh?
I think I don't have much experience of back these cases, rather in these cases, sir.
Okay.
Sir, for us, the company people itself, they say it is not applicable if the bone is exposed. So we have not used it.
No, not when the bone is exposed. What in the first case and in this case, what has happened is we have excised all the bone. There is no bone exposed. But what Ram Karthik is saying, that you have opened up the medullary canal
Medullary
and all as
canal,
part of
yeah.
debridement. So there is theoretically a open medullary canal. My argument is that one, we have closed it off with the cement in this case, and in the earlier case also we have used it kind of guardedly, in the sense of lower pressures initially. That is my reasoning.
Yeah, but definitely it will help if the medullary canal is open, sir. It will drain out all the intramedullary or remove all the
No, but
glycocalyx
one of the
fluids.
contraindications of WAC, they say, is if you have got something which is exposed, then he can bleed through that. That's what he's trying to point out.
Yes, sir. Medulla, if there is more correction there, he may go into hypovolemia, sir.
Correct. So you do it in a guarded fashion. By that argument, you should not keep a suction drain also if the medullary cavity is open.
Yeah.
So yes, theoretically that point is correct, but if you keep proper attention to it, that should be okay.
Okay, sir.
All right, let's go to the next case.
Yeah. Yes. Now we have Dr. Ketan Kumar Gandhi.
Yes, sir. Is that visible, sir?
Yeah.
Yes, sir. Good morning, everyone. I am presenting a case of infected non-union of tibia, which was managed with Ilizarov bone transport, and then we had a refracture. So this was 52-year-old male, was operated elsewhere. This was the X-ray when he presented to me. He had multiple surgeries in past. he did not have record of his all those previous X-rays, but I could find this one. This was the immediate post-op after his open wound, open fracture. He had been nailed, and not the immediate post-op. This X-ray he had been nailed, and then after a few months, he still had discharged multiple sinuses. We can see some necrotic, probably sequestrum at the fracture site, and the implant has failed. Proximal bolt is broken. So at this stage, he had come to me. So we have given him an option of implant removal, thorough debridement, and Ilizarov ring fixator, and maybe if required, bone transport if the gap is too much after debridement. So this was the one when he presented after implant removal. Implant removal was done somewhere else. The broken bolt, the distal part could not be removed, and the infection was still persistent after implant removal. So he had multiple sinuses draining, which eventually healed, but one sinus remained, and that was still active and persistently discharging pus. So we took him up for surgery. We did debridement. We removed all the necrotic white-looking bone at the fracture site, the necrotic granulation tissue which was in the medullary canal. Maybe we felt that when the implant was removed, the canal was not thoroughly reamed, so the infected granulation tissue was still there. So we reamed the medullary canal. We removed all the necrotic pieces, and this was the X-ray after final debridement till the fresh bleeding edges of the bone. So Ilizarov frame was applied. Proximal corticotomy was done for bone transport to fill in the gap. And as that proximal part had healed till that time, we took him up for surgery. So we did that corticotomy in the same setting. This was gradually when the bone transport was in progress. At 3 months, there was docking, but the alignment was not good, and we thought that there might be some fibrous tissue. So we did open docking, corrected the alignment, put some bone graft there. Regenerate had now started consolidating well. At 3 months after bone grafting, the even docking site was non-tender. The sinuses had all completely healed. There was no sinuses. I mean, the wound had completely healed. There was no infection. But he had one bleb and which burst out and formed a sinus at the proximal corticotomy site. And you can see a cavity developing there in the proximal corticotomy site. At 5 months, the frame was removed. The bone had healed completely. The alignment looks reasonably well. There was some small sinus at the proximal corticotomy site, which was regularly managed with daily dressings, but it was not profusely discharging. There was no surrounding signs of inflammation, just a quiescent sinus, which was discharging every couple of days or 3 days maybe. He had started walking with brace. So at this point of time, at this stage, I want to ask the seniors. So till this time, is this okay, or do you think something else could have been done, or something is not done correctly?
Amar, Suresh.
Sir, is there any flexion deformity at the knee? Because in sagittal plane, in the final X-ray which you have shown, sir, there is this. The plateau has a tendency.
This was the X-ray taken in lying down position, so maybe the patient has kept the knee flexed. There is no flexion deformity, sir.
No, the bony, sir. The bony issue, the plateau in the.
Yes, the tibial slope looks increased.
Again, this is a rotation. See, normally your fibula is, this is an internally rotated view. So there you can't actually comment on the PPTA.
Right, sir.
At this stage, sir, what I thought was maybe I did corticotomy in the same sitting when I did proximal the debridement and Ilizarov ring fixation. Could that be a reason that my corticotomy got infected and there he developed a sinus?
Yeah, now with 2020 hindsight, one can always claim that that is the reason. But can one really say? But yes, as a general rule, if there was a intramedullary nail and that's an infected thing, I would take it for granted that there is some infection in the medullary tract, and
But
I
then,
will always do that corticotomy
yes, but
later on.
when I took him for surgery, sir, the nail had been removed couple of months before, and there was only sinus at the fracture site and not at the corticotomy site.
Yes, but there was biofilm on the in the tract.
Yes, yes, yes.
So
So in the
the
hindsight,
way
I
I
too feel the same. I
yeah.
might have delayed corticotomy.
So the way I
What
look at it is when I take out the infection, then I get a I get a handle on what is the organism. We are also treating it with antibiotics. So then that debridement as well as antibiotics will take care of the infection in the proximal portion, and then I will do the osteotomy. So almost, I would say I don't remember any particular case with a nail where I would do the osteotomy at the same time. I would
Yes.
always, what does it take? I mean, it takes a additional 4 weeks later, 6 weeks later, you do it, and it's a 10-minute job, no, to do the osteotomy. I set it up for an osteotomy and I do it 4 to 6 weeks later.
So another reason when I reviewed my X-rays in the hindsight, the corticotomy was slightly traumatic. It was not exactly a traumatic corticotomy. The anterior cortex looks in AP X-ray there was some comminution. So could that be a reason?
comminution per se is not the reason for infection.
Then maybe because of that there was a cyst formation and which later got infected.
That is not a reason.
Less likely. Less likely.
It looks that there is
I
a
have many. Sorry,
posterior, I mean, medial, medial, if you see, there is a lytic lesion in the corticotomy area, which could have been a old sinus, which has got active now.
That could have corrected in the first sitting.
So I've had multiple times I have slight comminution in the osteotomy and no problems, touch wood, in those. So I don't think comminution in itself this is a low energy comminution, so it's not a problem. It just shatters into multiple directions. That's about it. Okay, so tell us then what.
Sir, this was the clinical picture. There was a very small sinus, which was for most of the days it was poisoned, and maybe once or twice a week it was discharging. So patient was also not worried of that. He had started walking with brace, and suddenly one day he tipped again. There was a trivial twisting injury, and he came with this X-ray. He had a distal tibia fracture, distal to the docking site, which was there previously. If I go to the first X-ray, it was a segmental kind of fracture. There was distal tibia fracture which had healed, and now he has this fracture after frame removal. Almost 3 weeks after frame removal, he had a trivial fault. He did not use brace that day, and he got this. So now at this stage, sir, patient had been given two options of operative management and non-operative management. I explained him everything. What are the pros and cons of conservative management, operative management, whether we should again go for Ilizarov or we can try plating. But given his history of infections and multiple surgeries, we did not want risk of infection. So I had given him, I was inclined to give him operative management option, but somehow he refused, and he said that he needs time to decide it, and he came back after 2 weeks. So I gave him slab. He came back after 2 weeks. After 2 weeks, he was very comfortable. His pain had gone. He was feeling good. The fracture pain had gone, and with brace, he had started non-weight bearing walking. He had been mobilized with walker, non-weight bearing. So as he was very comfortable, he said, डॉक्टर साहब अभी तो मुझे ठीक लग रहा है, ये ऐसे ही हो जाएगा, आप प्लास्टर कर दो, अभी ऑपरेशन नहीं करना. So I was, uh, uh, I had given him, I was inclined to give him operative management option, but somehow he refused, and he came back after 2 weeks. So I I was very skeptical doing that, but because I did not know whether it will heal in plaster, I had given him chance of a choice of surgery, but he refused. So we did cast for him, and at 1 month, he showed, to my surprise, he showed good callus on the medial cortex as well as lateral cortex, anterior cortex. So then, even I was at my peace of mind. I continued cast. 2 months in cast, then cast was removed and brace was applied again. And this is the 3 months post refracture X-ray. He has no pain. There's no mobility. He is now walking with the brace again. There's no infection at this fresh fracture site. The proximal sinus is still discharging now and then. This is the recent X-ray which he has sent. He is walking with the brace, and there's no issue with the distal fracture site, but there is sinus persistent proximally.
So interesting. That was a low energy fracture.
Yes, sir.
And that is therefore that is not giving any trouble. So the point you made about clinical appearance, in clinical not appearance, how the patient presents, that 2 weeks later, once the patient is saying that okay, I am quite comfortable, that gives you the option that okay, let's wait and watch.
Yes.
If patient is walking well, then you can always wait and watch. Now the other question is what to do for the
proximal sinus. I have given him option of debridement, but as that cavity is so narrow, I don't know how will I debride. I might have to use mechanical burrs and put in stimulant or something. But looking at the cost of stimulant and one more surgery, he is not yet ready for it.
Yeah, but you could even just curate it out with a small curate and then give him appropriate antibiotics if you get
I did that, sir, when I removed Ilizarov frame, but that somehow didn't work. When I removed Ilizarov, I curated that tract, but it again reappeared.
Okay. Any other suggestions, Jayant?
If he is not willing for surgery, sir, at this moment.
If he is willing, sir, what should I do? If he
saucerization,
I'm willing
a proximal saucerization.
So should I remove the whole medial cortex and open that cyst, deroof with that cyst?
A saucerization would not require a total removal.
Saucerization? Saucerization of what? That cavity? No, if the skin on top is a sinus directly uske niche sinus hai, then that may be a issue. There are couple of suggestions. Ram Karthik says hollow mill. Okay. Hollow mill for what, Ram Karthik?
Sir, sinogram and if the sinus is through the bone, hollow mill that sinus, sir. We can access that so that it will be circular and chance of refracture will be less, sir.
Take out bone around the thing, similar to what you are saying, where you have to use a burr kind of thing.
Yes,
He's
sir.
saying use a hollow mill. Aradhna says, can you get a CT? Yes, that's one possibility. If there is a hidden sequestrum, you can get a CT. Dr. Surinder Sarangal, I think. Shall we put antibiotic beads in the nail tract for 4 to 6 weeks? Yes, if I often do a PET CT, and if that shows that the entire medullary cavity is lighting up, then I ream it out, plus I put stimulant bullets they have, which are larger size. They are costlier also. But otherwise, I don't put in stimulant into the medullary cavity. I just rely on the fact that I have reamed it out as well as what culture I have grown. So ideal protocol, if your patient can afford and you are sure that the infection is right up, like for example, there is an infected nail, discharging sinus at the fracture site, discharging sinus at the entry point or proximal locking screw, that will tell you that, that entire canal is infected. So in that case, you could consider reaming as well as stimulant. So that can be considered, but not, I don't think it's needed in every case. Many a times it is the frank infection is at the non-union site, and there are sort of what you call biofilm along the tract, but it may not be a frank infection. So after 4 to 6 weeks, if everything is settled, CRP is okay, then I think it is safe to go in for a corticotomy. But if you are worried that there is active infection along the canal, then even antibiotic-coated nail is one of the options in that situation, which works okay. I mean, we've done that in the femur and stuff, where the Ilizarov is not as easy as it is in the tibia for the patient. Right.
Sir,
So,
I have one more question, sir, to the seniors. So, post Ilizarov frame removal, which kind of brace we should use? Maybe we should always make a thermoplastic molded brace according to the patient's shape and sizes, or can we use a ready-made available PTP braces, or even a air cast boot? Is that sufficient?
I tend to not use any brace. I prefer the Ilizarov until and unless the patient can show me that patient, with the stress test, that patient is walking with the rods disconnected. Now, after that also, if I am, let us say, still a little worried, then I would probably give them in a patient like this. It depends on what you are worried about. If you are worried about the non-union site, then a cast is okay for 3 weeks or so, and then see how things are going. If you are worried about the proximal regenerate site, then I would give a full length, long leg cast.
Okay.
And I tend to give custom braces. I don't think the off-the-shelf braces will not work in many of these guys, because they don't have a good hold. Rather than that, I say give a cast. Like if you don't have access to orthotics, give them a cast and change the cast at 4 weeks, 6 weeks, whatever it is.
Okay,
What do you all do? Amar, do you use? I normally explain to the patient that, see, I can take this off and give you a brace, but again, in the brace, it will be tight, you will have sweating. Compared to that, the fixator is actually easier, and many a time the patients themselves understand, yes, we will go with the fixator. Amar?
So, sir, in early years of practice, we used to succumb with patients' demand of early frame removal. But now, once adequately counseled, patients are not that keen for early frame removal. And if patient is asking for frame removal, there must be some reason, miss pain or some issue, or he is in financial issue or travel issue. So, by and large, I would prefer to keep frame for longer period than to remove it. If in
Correct.
doubt, then I may opt for putting internal fixation or even supracutaneous split if skin condition are not good. Brace would help in a borderline cases, but if it is clear-cut non-union, then brace is not likely to help.
And it's more for mental peace of mind,
Yes,
my mental peace of mind,
yes,
rather
yes,
not even the patient's mental peace of mind.
yes. It is to prevent refracture rather than to protect.
Yeah.
Okay. Thank you, sir.
Thank you, sir.
Do
Next,
you have any?
Dr. Washif.
Yeah.
Once again. The screen is visible, sir?
Yeah.
Okay. Good morning, faculty and seniors. The advice that I'm seeking today is for a case of infected non-union shaft tibia managed by Ilizarov ring fixator. So the patient is a 42-year-old male with history of RTA 4 years ago, leading to compound fracture shaft tibia, for which he went at external fixation. The pin sites got infected and the fixator was removed within 3 months. Patient landed into non-union with discharging sinus present over the anterior aspect of the leg. Patient didn't seek any medical intervention for the next 3.5 years, except for a debridement. 7 months later, 7 months ago, the patient went to another orthopedic surgeon elsewhere, and 9 centimeter of bone from the non-union site was resected. Corticotomy and bone transport was started with the Ilizarov ring fixator. So, as the presentation says, what all was wrong with the original frame?
Do you have any X-ray prior to this frame?
No, sir. Sadly, I don't. I'm sorry.
Okay.
This is how this is the post-op day 1 X-ray after the original surgeon had applied the frame. What went wrong with the frame, I think, is it was an all-wire frame which was highly unstable. The 4 rings were connected on
Why are you
single
saying
rods.
all wire frame is highly unstable? It should not.
No, it shouldn't, but I'm pertaining to this particular case, sir, wherein the wires, as you can see, the wires are not tensioned properly. And apart from that, the wires are inadequate, like
Yeah, you can
in
say that,
areas.
but that doesn't mean all wire frame is unstable, no?
Has
This
to
is
be
No,
added to the
not.
drop wire. Drop wire is
Yes,
less.
but
Single level. Yeah.
my statement was related to this particular case. So the 4 rings were connected on single rods through and through. The frame was not aligned to the tibial axis. Wires were tensioned inadequately. As you can see in the ring 4, the 2 wires, ring 3 and 4 as well, the 2 wires were at a less divergent degrees, less than 20 degrees actually. And the transport fragment was poorly controlled. The ring at the transport fragment was at the proximal region and just 1 wire passing through. Still, the original surgeon started the transport. The patient was having difficulty bearing weight. As the transport was started, the proximal fragment started going into angulation. As the frame was unstable, the patient was having difficulty bearing weight. The transport fragment started translating anteriorly and medially. Now, the surgeon introduced the shunt pins into the picture. He introduced 4 shunt pins from the anteromedial aspect, 1 in the proximal fragment, 2 in the transport fragment, and 1 in the distal fragment. He continued transport for the next 2 months on that frame itself. Still, the patient couldn't bear weight. The transport fragment continued translating anteriorly and medially. Transport was finally stopped when the transport fragment came to lie just under the skin, and the impending skin piercing was observed. The patient was in this condition for the next 2 months and later came to us. So this is how the patient. This is the picture of the patient when he came to us. I was worried about the skin being impinged and the piercing. So the revision goals for this patient was to improve stability, restore alignment, obtain adequate transport fragment control, enable weight bearing, restart transport, and address the impending skin piercing. So for those, the measures that were taken were as follows. I broke the single rod construct and individual connections between each rings. The blocks were made. Translation was addressed with hinges. Stability was increased in ring 1 by introducing a anterolateral pin. The ring over the transport fragment was moved distally. 2 wires were introduced and 1 pin. Pins were added in ring 3 and 4, and the wires were removed from 3 and 4, and correctly divergent wires were placed. So now I was worried about premature consolidation since 2 months had passed, but the patient couldn't afford CT, and I just went ahead and started distraction. The patient was able to bear weight. As the fragments aligned, the skin condition also improved. So this is the picture after 20-25 days of starting the transport. The things I'm worried about is the regenerate quality, the proximal fragment angulation, and the docking site. So that's it. That's the current picture right now. So I would like the advice from you also.
So now your worry is what?
I'm worried about the regenerate quality, sir, and the proximal fragment angulation. I didn't open the regenerate area during the revision, and now should I go ahead, should I correct the angulation, and what should I do about the regenerate quality? Should I do an intervention? I tried counseling the patient for teriparatide, but again, he was not willing for that.
So affordability means what? Patient is absolutely
Financially, sorry, sir.
Absolutely not able to. One thing you can do for the regenerate is if you have a good radiology, you are in a medical college.
Yes, sir.
So if you have a good X-ray department who will read up and do ultrasound, you can assess regenerate. There are articles where you can assess the regenerate by ultrasound that shows you the flakes of ossification. You have not done anything. You're not distracting the regenerate, or are you?
No, I'm not, sir.
Yeah. So one of the things will be to kind of see what the regenerate is like. Get the problem with regenerate now is that when it's in the transport phase, regenerate is not being subjected to any load. So the ossification
Yes,
may
sir.
not be visible on X-ray, but you may see regenerate on ultrasound with flecks of ossification. So
Okay, sir.
that would be one thing. Second thing could be to go back in terms of the distraction and see whether it is going back, and then treat that also as a non-union and do a separate osteotomy. Try and
Osteotomy.
get contact between the proximal, that is the transport fragment, and the distal fragment by closing up that gap.
Okay,
For
sir.
that, you'll need to do a long oblique fibular osteotomy so that it allows for that overriding to happen.
Okay, sir.
Right? And then once you have that contact, you will have a leg that is shorter, but where the patient is able to weight bear. So
Okay, sir.
these are all your options. Now, even if there is some minor angulation, etc., given the number of problems that this guy has, I would put that as the bottom of the list. I mean, I would not
priority.
Itna mujhe, I don't see so much angular problem that it will impede healing. So I may discount some minor angulation as long as I have good contact and healing is progressing. You may require in the future grafting at the regenerate site. If it doesn't, if it's not collapsing and it's not ossifying, then you may need to graft there as well as at the non-union.
Docking site.
Yeah. Let's get other opinions also. Amar?
So,
Jayant?
means we can compress the docking site for a while and wait for a few weeks and then, regenerate site and then redistract. Second thing, we can have a pin which is spanning in a more better way in a transported fragment and ensure that all wires and pins are in good hold. Let patient walk and have good nutrition. So these regenerate issues should improve. I don't think that he'll not have any regenerate.
Correct.
Okay.
That's what. So the regenerate, as I said, Amar is basically saying the same thing, that the ossification of the regenerate may not happen, does not happen in these transport fragments. Still, there is contact. and weight is transmitted across the regenerate.
The regenerate. Yes.
So the best way to assess it now is I think ultrasound. And
Ultrasound.
compression also will give you a kind of what do you call alternate way of looking at it. Agar compress, if it's not compressing, then there must be something in there.
Got it, sir.
Joydeep, you have any thoughts? How would you deal with this?
Yeah, I think, sir, I will try to distract it. I think it will be distracting. No issues will be there. And if it doesn't, I will wait for some time and redo the corticotomy. I don't think it will be much
After
of a
2 months. After 2 months, it will distract.
Yeah, I think so. And
After,
if it doesn't
suppose
distract,
this was
we can just remove the rods and give it a twist and restart distracting, I guess, sir. Because
after 3 months. Suppose this was 3 months.
we can, if it's not distracting and we can see, sir, good amount of regenerate in there in the X-ray, then we can do, sir, recorticotomy in that part, sir.
Correct. So you need basically what you need is an algorithm that, okay,
Yes.
if this happens, this is what I will do. If this happens, this is what I will. So you have to plan all your steps ahead of time. That, okay, this, for example, Joydeep says that I think that this is not fully healed, and I think that the distraction will occur. So therefore, I will go ahead with this plan. Now, 2 weeks, 3 weeks after that, if I find it's not distracting, then I will change track and I will do, X, Y, Z. Amar said the same thing. That
Yes, sir.
if this happens, then I will do this kind of. So you have to have a kind of roadmap in terms of what I think is happening, what I expect to happen. If that doesn't happen, what will I do?
Got it.
And otherwise, I think you have a fair understanding. One more point which Amar made was you've got good control of the transport fragment in terms of the fact that you have now fixed it distally.
Yes, sir.
But if you look at this, that is for transport. But if you look at this proximal gap as a non-union, then you do not have a good hold. So what he said was put a drop Shan's pin proximal to the ring so that you are holding a larger expanse of the transport fragment. If at all
Okay, sir.
that regenerate area is tending to become a non-union, then you have a better hold on that. This transport fragment, as you have put it now, will be stable when it is distracted. When it is like this, it may not be equally stable. So you need to put in one more fixation proximally. I am hoping that the way you have dissected it, you have tensioned all of the wires and all properly. So from that
Yes,
point
sir.
of view, I think it should do okay.
Okay,
So
sir.
करके देखो, let us know then in one of the agla meetings.
Yes, sir.
So
Okay.
Yes.
Jayant sir has shared an X-ray in the chat box of a case of fibrous dysplasia. I'm sharing my screen. This is the X-ray.
ओपन तो कर पहले.
दिख रहा है सर?
नहीं, पूरा स्क्रीन दिख रहा है.
नहीं दिख रहा है.
Share your full screen and open that.
Just select the picture first. Yeah.
Now?
No.
Not yet.
My screen is visible, sir.
Screen is
Whole
visible.
screen is visible, which needs to be organized.
It's there in the chat box.
Yes. अभी भी नहीं दिख रहा है सर.
ना.
नहीं.
No, कुछ प्रॉब्लम है इसमें. नहीं हो रहा है.
Okay, I will share my screen here. दिख रहा है अभी?
Yeah.
Yes.
Yeah.
This was the case and came on Saturday. Should we go for resection and Ilizarov or non-operative medical management?
For non-operative medical management, this would be pretty thin bone, I think.
Okay, sir.
So either you just do a excision of that area, say from here to here, and do a bone transport.
Yes.
I would agree with that. Any other opinions?
So injection denosumab will help in this case. It will solidify the cortex. Then we can do a grafting.
Which cortex? There is no cortex over here.
Anteromedial cortex, whatever is left, sir. With injection.
Anterolateral, you mean?
No, there is a shadow of cortex on the medial side.
Okay.
It should get solidified with injection denosumab.
He had a pathological fracture, after which he came to me with this X-ray.
Yeah, but so I mean, you can't argue against what Joydeep is saying in the sense that what is the worst that will happen? It won't
So
work.
Actually, sir, I've seen my teachers do it in cases of GCT. I don't know whether it will work absolutely in this case, but in GCT, they give the patient 2-3 doses of denosumab, wait for the cortex to get solidified, then they do curettage.
Yeah. So worst thing that can happen is it doesn't work. Then the backup is always there. I think worth trying.
Yes.
And then letting us know. All right. Good. So we finished in time.
Yes, sir.
पंकज भाटिया अभी तक काम कर रहा है. संडे को छुट्टी होता है बाबा. ठीक है. चल. Thank you everyone.
Shamsul, regarding the next webinar of the zone, you are wanting to say something?
Yes, sir. So we have the next South Zone webinar on 19th of June, the third week, Friday night, 9 p.m. onwards. So Dr. JJ is moderating. He has a list of keynote speaker and speakers. So we'll be releasing the flyer soon, maybe on Monday. So request everybody to log their dates for 19th of June.
This is 1 week ahead before the schedule because of Moram being the next Sunday. I mean Friday.
Right, sir.
Okay.
Sure.
So, Manga sir, is that okay? The date is okay, sir?
Yeah, should be okay.
Thanks. And then again, I'll be requesting everybody to send their cases for next month's